Hello and good evening to everyone. I am Dr. Vipul Chavda from Rudraksh Institute of Medical Sciences from the city of Ahmedabad, and today we are here with one more episode of He for C, the campaign that is for women empowerment and how men can support the women for their empowerment. Today we have Dr. Tarni Vyas, who is a eminent diabetologist and very young and enthusiastic doctor from the city of Ahmedabad, and she is moderating this session. So I would invite Dr. Tarni to do further proceeding. Over to you, Tarni.
Thank you for your generous. So the speakers for today are Dr. Shruti Kohli. She is the only female cardiologist from Uttar Karnataka. I'm honored to introduce her to this platform. And we have Dr. Sanjeev as well, but he'll be joining in a while. I just want to let the speakers know that for educational purposes, this is being recorded. And whatever questions we have, we'll take it up after the session gets over. So, Dr. Shruti, can we start with knowing what is the prevalence of cardiovascular diseases in women as compared to men, and what is the current scenario? Where is it going?
Thank you, Dr. Tajni, for those kind words. So, coming to the prevalence of cardiovascular diseases in women. So, we know that the cardiovascular disease is the leading cause of death. So, the prevalence, cardiovascular diseases are mostly seen less commonly in younger population, and in people who are more than 40 years of age, it is seen in every alternate woman. So if I have to talk about particular disorder, then in coronary artery diseases, they are seen in 1 in 3 women, and heart failure, stroke, they are seen in 1 in 5 women. So, and about the death, according to 2018 registry, so what we can see is 1 in every 4 women, they die of cardiovascular disease.
That is a very prominent number and too much of relevance now. So we are glad to being doing this awareness thing about women health.
Yes.
How is women's health generally different from men's health? How will you describe it different?
So generally, women's health and men's health, if we have to differentiate, we can categorize them broadly into 2 categories. One is biological differences, and second one is gender-based differences. Biological differences are mostly related to the chromosomal or genetic variations between men and women. And gender-based differences are nothing but the psychosocial and behaviors that have been imposed by the society on us. So this is how we can differentiate between men and women's health in general.
Okay. Can you enlighten us about the risk factors for any of the cardiovascular diseases, not just MI? Generally, people think that whatever cardiovascular disease is just limited to myocardial infarction, but it's not. So can you enlighten us about the risk factors of different cardiovascular diseases that exist?
So in general, if we have to talk about risk factors, including both men and women, then there are diabetes, which is a major risk factor, then hypertension, and obesity, overweight and obesity, and physical inactivity, and bad habits like smoking, tobacco chewing. So they're all, they come under the category of traditional risk factors. And certain sex-specific risk factors, if we have to stick to women's health, then before I move on to the pathological aspects, I will emphasize few points on physiological aspects of women's health in terms of this attainment of menarche, early attainment of menarche, that is less than 12 years, and delayed attainment, that is more than 15 years. They are at risk for cardiovascular diseases, and also worse outcome are seen in such age group patients. And coming to early menopause, that is ovarian dysfunction, then in them, the coronary artery diseases are most commonly seen. So moving on to the pathological aspects like PCOD, which is seen in women. So PCOD is a major risk factor that causes insulin resistance, glucose intolerance, overweight, obesity. All these are directing towards the metabolic syndrome, which is a major risk factor for cardiovascular disorders. So then other disorders like, the breast cancer. So the ionizing radiation as a part of radiation therapy for breast cancer, it can cause coronary artery disease. So one interesting point here is the coronary artery diseases are seen most commonly in left breast cancer than right. That is because of the irradiation on the precordium. And moving on to the pregnancy itself is a risk factor for cardiovascular diseases. So, like pregnancy is a hypercoagulable state and, high volume state where we see a lot of thromboembolic events in pregnancy, not just the coronary artery disease. We see a lot of thromboembolic events like CVT and pulmonary embolism, DVT. These are very commonly seen in pregnancy. And other aspects like the disorders compared to the pregnancy and non-pregnancy, the gestational diabetes mellitus, even the hypertension, eclampsia, preeclampsia, even the preterm delivery, they are all at high risk for developing cardiovascular disorders, even in the later age. So this is about the pregnancy and other risk factors, if I have to quote, like autoimmune disorders, like SLE, rheumatoid arthritis, Takata-Subba cardiomyopathy. They are, of course, seen in even men, but they are more commonly seen in women. So it is said that SLE can cause 9 to 50 times higher the chances of cardiovascular disease than in general public. So yeah, so and also peripartum cardiomyopathy, so it causes heart failure. So these are certain risk factors of cardiovascular diseases in men and women.
So, like you mentioned, menarche and pregnancy. Can you enlighten us about the incidence that is happening? Is it in younger population also, or do we still continue seeing it in older population?
About the cardiovascular dysfunction you're asking? Yeah, so post-COVID, of course, we are seeing a lot of thromboembolic events in both women and men. And smoking and tobacco chewing is predominantly seen in men, in our country at least. So we are seeing a lot of younger generation coming up with myocardial infarction, pulmonary embolism compared to women. But post-COVID, yes, of course, we are seeing a lot of younger women presenting with myocardial infarction.
Okay. How does pregnancy impact a woman's CV health in short-term basis and long-term? Are there any long-term implications also?
Pregnancy, as I mentioned, it itself is a high volume and hypercoagulable condition. So pregnancy can cause the thromboembolic events. And if I have to quote about gestational diabetes mellitus, it has 7 times higher incidence of type 2 diabetes in the later age. So, and coming to this eclampsia, preeclampsia, so what we have seen is higher the severity, more the severity of this eclampsia, preeclampsia is directly related to more severe cardiovascular diseases in future. And early eclampsia or early incidence of preeclampsia has caused early incidence of cardiovascular disease and adverse outcomes in terms of cardiovascular dysfunctions in the later age group. And preterm delivery, yeah, so that causes more of inflammation, microvascular dysfunction, endothelial dysfunction. So those cause coronary spasm. Those are some reasons which cause a demand supply mismatch. So that causes ischemic heart disease. And pregnancy, peripartum cardiomyopathy, of course, which we see in last trimester to few months after the delivery. So they present with heart failure, repeated admissions, poor outcome basically.
Yeah, wonderful moderation by Dr. Tarni and Dr. Suti. You are enlightening a wonderful thing that cardiovascular disease are not sparing female, that we assume that in the early 30s and 40s they are not getting coronary syndrome. So I would like to ask that in Indian scenario, when females are not ready, that I have observed in my hospital, which is in suburban area, that females are hiding their symptom. They are not readily expressive that I have chest pain or I want to consult a doctor. If the man has the same symptom, they will move the whole village or they will go to any bigger city or bigger hospital. But female heads or complaint, female herself is hiding the symptom. So I would like to ask from your experience that what are the unique challenges that you face when women has a cardiovascular disease in terms of diagnosis and even for the therapy, because therapy for cardiovascular disease are not that cheap. If you want to stenting them or if you want to do some other surgery, female will take some step back, that they are not ready to spend money for herself. So what are the unique challenges you are facing when the same age group and having the same complaint, but if the gender is female, in terms of diagnosis and therapy?
So very rightly pointed, we are really facing a lot of challenges in identifying in, there is a lot of delay in the presentation. And yes, they are definitely hiding because they don't get the attention as they get, as men get the attention. So there is lot of underdiagnosis, misdiagnosis, and there's lot of undertreatment and poor compliance to the medicines as well by the women. And also when it comes to intervention, like you said, yes, there are acceptance for the disease is very less when it comes to women than men. And the intervention, of course, that is really challenging. The acceptance is very poor. So another thing is about fibrinolysis, the treatment what we give, it is time bound. The presentation is so delayed that we cannot give fibrinolysis to women when we compare to men. So
So now,
all these things I think we can come across purely by awareness, creating such programs, I would say. That's all. A lot of healthy heart programs or women-oriented programs we have to create and, make them aware about the cardiovascular health. And to this, I would like to quote a point that in 1990s, when a survey was made, I think 30% of the women are also unaware about cardiovascular disease being the leading cause of death. And when it came to 2000, I think 15, they did one more survey. About 50% of the population, they were aware that the cardiovascular disorders are the leading cause of death in women as well. So I think that has plateaued afterwards. So that shows that some amount of awareness the people are getting now. Social media has played a big role, I would say.
thank you, Dr. Suti, for wonderful elaborative and data big information. Now we have Dr. Sanjeev Phatak, sir. Uh, Actually, sir, don't require any introductions. He is guru, mentor, teacher of all of us. But as the peoples are listening here, I would say Dr. Tarni to formally introduce and welcome Dr. Sanjeev Phatak, sir.
Good evening, sir. Dr.
Yes, good
Sanjeev
evening.
Pathak.
My apologies for joining late.
No worries, sir. Dr. Sanjeev Phatak is a leading diabetologist in the city of Ahmedabad. He has been practicing diabetes since 30 years and he has immense knowledge and is a great clinician to learn from. Sir, we were discussing about the prevalence and the disparities what women and men face when encountered regarding cardiovascular disorders. So, will you enlighten us about the prevalence?
Yes, sure. I think though I joined late, what I could make out from Dr. Shruti's talk that women probably are diagnosed late. They also present late. And the awareness of cardiovascular disease, as per the survey she discussed, is also less in women. And that is not only true for the rural women, it is also true for the urban women. I would like to add to that. It's not that only in the villages they are not knowing about the risk of cardiovascular disease, whether diabetic or not diabetic. Even in the cities, people feel that women do not get cardiovascular disease. Though the analysis, especially of the diabetic patients, shows that cardiovascular disease is actually much more common in women compared to men. So we need some focused programs that would make them aware regarding the cardiovascular disease, regarding the risk factors of that, regarding the early diagnosis of that, the warning symptoms, and the routine screening, especially in the high-risk women, so that we can detect the disease early and can prevent the morbidity as well as the mortality associated.
So, sir, there is also a difference in men's and women's behavior when they are having a anginal symptom or some chest pain or other thing. And females delay their symptoms to present to their family members as well as to clinicians. So, what specific precaution we need to take specifically when we are diabetologists and seeing diabetic patient for long duration? And sometimes we may overlook or we may miss the symptom if the patients are not presenting well. So, what are your suggestions that we should do in our practice?
Correct. So there is a paradox. At times, many of the symptoms which are very vague, say chest discomfort, some pain, sometimes the gaseous discomfort, and these symptoms sometimes are not organic also. And what happens in clinical practice during the busy hours? Sometimes clinicians tend to miss, even the relatives also miss कि भाई ये तो उनको थोड़ा psychological हो रहा है या गैस का हो रहा है. On the other hand, these are the symptoms where we should be picking up the disease early on so that we do not miss out of that window period of the thrombolysis or the PAMI, what we call. So the paradox is, on one hand, women have tendency to, sorry, Tarjani and sorry, Shruti, but I'm talking about women in general have tendency to over-complain some of the symptoms, but at the same time, they ignore the important symptoms. So these warning symptoms, we must tell them that if you develop any of these symptoms, simple chest pain is okay, but chest pain associated with exertion, chest pain associated with radiation to the back or any of the shoulders or hand or jaw, or some gaseous feeling which was never there. If they do not ignore these symptoms, probably we may be able to diagnose it very early in most of it.
Before we
Compared
start,
to that, man, I don't say that they underreport, but they, of course, even in man also, we have found that they are scared of the interventional procedures done by cardiologists. And that's why they also hide the symptoms. So it's equal for men and women, but in women, you can see this paradox. That's what.
so before we start this webinar, we were discussing with Dr. Shruti that the pathophysiology of coronary artery dysfunction in terms of atherosclerosis and blockage is also different in men and women. She was talking something about myocardial infarction with normal coronary arteries. So Dr. Shruti, would you like to explain our audience that what is that phenomena and how it is happening?
So most of us, even in our cardiology training, we consider myocardial infarction as coronary artery disease, which is not true. So a patient has developed myocardial infarction, so rush him to a cath lab. So yes, you have to do that. But there is a difference between ischemic heart disease and coronary artery disease. Ischemic heart disease is demand-supply mismatch, wherein coronary artery disease is purely related to anatomical obstruction of coronaries. So this difference we have to know about ischemic heart disease. So the ischemic heart disease is seen more commonly in women, whereas coronary artery diseases are seen more commonly in men. So ischemic heart disease, as I said, it is demand-supply mismatch. So there is something called as MINOCA and INOCA. So they are myocardial infarction with non-obstructive coronary arteries. So that is MINOCA. INOCA is ischemia with non-obstructive coronaries. So in women, the pathophysiology of ischemic heart disease is mostly related to myocardial dysfunction, the microvascular dysfunction, endothelial damage. They are more prone to have coronary spasm, even the spontaneous coronary dissection, I would say, which is more common in pregnancy. These are all more commonly seen in women, of course, along with the coronary artery obstructive disease. So this difference, in such patients, we see normal coronaries, but they have still presented with myocardial infarction.
Okay, thank you so much for answering the question. We have Dr. Firdos from Mumbai. Thank you, Dr. Firdos, for joining this important webinar. Now my question is that female, yeah, thank you. Females have so many hormonal changes during menstruation, even at the time of perimenopausal period. So I would like to ask question to both the doctors. That first, Dr. Sanjeev sir, that how these hormonal changes affect their glycemic status and whether they increase or not their coronary artery disease risk. And I would like to ask Dr. Shruti that how these hormonal changes may affect her cardiovascular health and what precautions she should take to have minimized this risk factor. So for Sanjeev sir.
So shall I start first?
Yes, sir.
Yes. So I fully agree with what Dr. Shruti told that women also have coronary artery disease with normal coronary arteries. And the reasons for that are sometimes hormone changes related also, sometimes thromboembolic phenomenon, sometimes stress, and the microvascular dysfunction that is there, which is there in men also. But in general, the women experience this more commonly compared to the men. So this is the difference that even with normal coronaries or even with normal calcium score, it is not very uncommon to have myocardial infarction or even acute coronary syndrome in women. So CSE of 0 is probably certainly related to very low risk in the men, but not in women. And some of the studies have also shown that even in absence of atherosclerosis, the risk of myocardial infarction still remains in such people. Now, coming on to the hormones and its relation to the glycemic status, yes, estrogen has protective effect on cardiovascular as well as the metabolic health. And loss of estrogen, especially after the menopausal age, is associated with more incidence of metabolic syndrome. As far as the glycemic control is concerned, if women is given hormone replacement therapy appropriately, it may have some positive impact on the glycemic control as well as the cardiovascular risk factors. Cardiovascular will leave it to Dr. Shruti to talk about. But yes, hormone replacement therapy or the hormones definitely have a positive role to play as far as the glycemic control is concerned.
Dr. Shruti.
Yes, it's Dr. Shruti.
So like Dr. Sanjeev sir rightly pointed that estrogen has definitely the protective effect on cardiovascular system. So that is, if I have to go more deep into that, the cardioprotective aspects of estrogen is basically due to the estrogen has positive effect on good cholesterol. So it increases high density lipoprotein, which is a good cholesterol. And also estrogen, it has a big role in arterial relaxation. So during menopause, there is decline in the estrogen level. So that causes decrease in the estrogen that leads to more arterial stiffness and increase in the bad cholesterol or LDL cholesterol and decrease in the HDL cholesterol. So all these things will increase the atherosclerosis in the blood vessels. So this is the prime reason prime reason for more presentation of coronary artery diseases in postmenopausal women than women during their reproductive period. And about the hormone replacement therapy, I have a slight different opinion, I would say. So the hormone replacement therapy, earlier, there were a lot of observational studies and hypotheses which were put forth based on this pathophysiology only, that it was put forth as, replacing hormones will reduce the primary and secondary risk factors, or will help in the prevention of cardiovascular diseases. But a lot of randomized control trials have come in 90s and 2000s, so which have shown, like even the Women Health Initiative, WHI, that has shown that hormone replacement therapy it doesn't have much significant benefit over the primary and secondary prevention of cardiovascular disease. In fact, they have shown that they have more common, I mean, they're prone for thromboembolic disorders than benefits. So now the guidelines recommend hormone replacement therapy only for the vasomotor, changes or vasomotor effects of postmenopausal condition, that too in low dose, and that too within first 5 years of postmenopause. But guidelines do not recommend hormone replacement therapy as a part of treatment or as a part of primary or secondary prevention of cardiovascular disease.
So what I believe, Shruti, is that the meta-analysis shown that the HRT definitely is associated with less cardiovascular risk and mortality, but it is associated with more thromboembolic risk. So
Yes.
the risk-benefit ratio is not in favor of HRT. But
Right,
it does
sir.
not mean that it does not reduce the cardiovascular. It does.
Right.
But the guidelines have to look at the overall benefit,
Yes.
and which is not there in the HRT because the thromboembolic risk becomes higher.
Yes.
But a woman who is less than 60 years of age, postmenopausal, and has typical symptoms, and less than 10 years of menopause, if they are initiated on HRT, the meta-analysis has shown that it is associated with less. I'm talking about cardiovascular risk. I'm not talking about thromboembolic. Thromboembolic risk is definitely higher in this women. And that's why the overall net benefit probably is not there. And that's why it's not as a part of the routine recommendation.
Right.
Right, sir. I would like to ask Dr. Shruti that what are the benefits of early intervention and detection on statistical basis when it comes to cardiovascular health? And sir, if you can give us insight about the clinical aspects, what have you seen in the clinical practice, or how early intervention can help and benefit the outcomes?
Shall I take this
Shruti,
up first?
yes, yes.
Okay. So there is this famous quote that time is muscle. So I'm sure all of us have heard about this. So that means time wasted is equal to muscle lost. So in cardiovascular disease, the time is very important. So like I mentioned earlier also, so early reperfusion, either it can be thrombolysis or PAMI, like Dr. Sanjeev sir mentioned. So that is very important and it is time bound. So our fibrinolysis is, we have something called as window period. So window period where the drugs will give best effect. So the window period for, the fibrinolysis, they have best effect within, when they are introduced, administered within 6 hours. Their best effects have been shown when they are administered within 3 hours as well. So as the time passes, the benefit is less. It's the same thing with even stroke. The window period for stroke is 4.5 hours, that is 4.5 hours. So the medicines will act best when they are given within that period. So the time is very important when it comes to cardiovascular disorders, especially the coronary artery disease. So myocardial salvage, we can do more myocardial salvage than when it is early. So the delayed presentation is equal to worse outcome.
How often and how frequently do you investigate for preventive investigation, not after it is detected or not after the symptoms are there? What do you practice before it can actually occur?
So shall I? Oh, yes. So routinely, according to the guidelines, routine screening in asymptomatic individual is not recommended. That's what the guidelines say. Because the overall people you will have to investigate to find out one coronary artery disease, probably the number is not that huge. But on the clinical basis, in our clinical practice, most of the patients which we see are high-risk people. And especially women, they are also very high risk because there are a lot of factors, as we already discussed, stress, the hormone changes, not being detected so early for diabetes. So they are also into the 7, 8, 10 years of into diabetes. So the risk obviously is more. We have typical dyslipidemia, our diet, our lifestyle, all this make us, and being Asian or Indian, makes us high risk people. And I believe that at least an ECG once in a year, blood pressure regularly, lipid profile, and urine albumin excretion rate, these are absolutely must as far as the screening method is concerned. In addition to that, we also routinely do coronary artery calcium scoring, though it is debatable. But we have found that it is a very good tool to identify atherosclerosis. You need not go for it very regularly, maybe once in 3 or 5 years. If the score is 0, no need to repeat for 3 to 5 years. But that also has been one of the important tests, though not recommended routinely in low-risk patients. But who is low-risk by that way? And that's why we screen men or women both routinely for cardiovascular disease prevention. In addition to that, if not the calcium score, we at least measure their Q-risk or ASCVD, whichever is feasible. Q-risk is more suitable for the Indian patients. And based upon the risk score, we need to treat them aggressively, maybe statin, antihypertensive, good glycemic control, the other lifestyle factors, so as to prevent the cardiovascular disease. So yes, even in asymptomatic patients, I believe that we should not be ignoring them, just considering that they are low risk and nothing would happen. But I'm open to debate and discussion with Dr. Shruti because the guidelines are other way around for this.
So I totally agree with what you said about screening. And what I want to emphasize is screening should be done, especially for people who have family history of diabetes, hypertension, or other cardiovascular disorders. So regular screening, we tell them to get themselves screened at least once a year with ECG and echo. If we have some doubt, if they have symptoms, maybe even non-specific symptoms, with normal ECG and echo, we subject them for treadmill test. So especially for people who have family history. So this is about screening. And about coronary calcium scoring, yes. So this particular age where we cannot call them as younger age group and we cannot call them as older age group, that is between 40 to 45, where they are they do not accept the disease very quickly. But when it comes to borderline lipid profile, when they do not want to take the statins, we subject them for coronary calcium scoring. So if the coronary calcium score is 0, then the guidelines say we should not give statins. We can wait and ask them for lifestyle modifications, and then we can repeat the test later. And so the coronary calcium scoring is basically recommended after 45 for the risk stratification, of course.
Yes.
So, Dr. Shruti, I would like to know what are the advancements that have been made in the detection, diagnosis, and treatment when it comes to heart diseases in women.
So if we compare to the older era, I think we are far ahead in identifying the diseases, in treatment, and of course for the screening purpose. I think we are fairly doing a better job. And but nowadays we have few advances which I want to emphasize on are something called as HSCRP, that is high sensitive C-reactive protein, and pro-neurotensin. These are all some biomarkers which can predict the future cardiovascular disorders. So, and we have this ASCVD risk score, so which can predict 10-year cardiovascular dysfunction. And there are certain tests like plaque testing. This is a lipid testing basically, it tests the lipoprotein A associated phospholipase activity, which is commonly seen in cardiovascular dysfunctions. This is also again a part of screening modality and also before initiating the statin therapy. So these are certain advances, I would say. But what we still need is better advanced risk stratification tools or risk scores, I would say. And we have certain biomarkers like NT-proBNP for heart failure, and we have this galectin for fibrosis, which are seen in higher range in women when compared to men. And certain biomarkers like troponin I, which are a biomarker for myocardial injury, and the biomarker as SST2, which is inflammation, they are seen in higher range in men. So we have this disparity in the range for the same biomarker. So we still don't have this sex-based ranges for biomarkers. That needs to be, the future, we have to think about such ranges and some advancement in the risk stratification tools, I would say.
That was insightful. I think from the audience, one of the questions was that only, are there any markers that suggest that this woman is at risk? So, sir, I would like to ask you, what advice do you give for the women who are concerned about their heart health and they are unsure where to start?
So first and the most difficult is, of course, the lifestyle, right? Very easily discussed, but very difficult to follow. And for women, there are more challenges looking at the social obligations they are forced into. So regular exercising, especially for the rural women, going out for walking and all that is sometimes still not that much popular or prevalent, or they find some challenges regarding that. Dietary also, I think there are challenges because in urban places, everyone has to eat out at least on the weekends. That has become a custom now. And for women in rural areas, again, they have some challenges regarding the type of food they should be eating for preventing all this metabolic as well as the cardiovascular disease. So that's a big challenge. But having said that, lifestyle changes are the most important thing, including avoidance of the unnecessary stress. Over and about that, routine screening, as we already discussed, the lipid profile, glucose, if the person is diabetic or not diabetic, hypertension, to detect hypertension, and habit cessation. Though smoking and tobacco is less common in women in our country, fortunately, but still, you have to ask about that. Sometimes women coming from villages may be habituated to tobacco chewing, or sometimes in Gujarat, you find tobacco paste also. So these things have to be kept in mind. In addition to routine lipid profile regarding LDL, one has to be very, very aggressive for lowering the LDL in high-risk people. Routine use of statin in high-risk people still is recommended and is having benefit much more compared to the risk. So these are the few points which can reduce the risk, but still a high residual risk remains. Whatever you do, diet, lifestyle, statin, blood pressure control, glycemic control, weight reduction, still you can reduce the cardiovascular risk only by about 40-50%, not more than that. So the residual risk obviously remains, and you need to find more and more solutions, non-pharmacological as well as pharmacological, to reduce that residual risk. Over to you.
Dr. Shruti, if you want to add something to it.
I would like to say that, the maintaining good habits is much, much easier than reversing the bad habits. So like Sanjeev sir said, lifestyle modification is really required for most of the population. And adding on to this is, I think we, being women, we have to consult our gynae before initiating the OCPs. We have seen a lot of women who initiate OCPs, oral contraceptive pills, on their own. So this is one thing. And another thing, we have to enroll ourselves in a lot of healthy heart programs, and the initiatives like a lot of walkathons, marathons are coming. So I think those things we have to enroll ourselves. So I think most of the other points have been covered by Dr. Sanjeev sir.
So I would like to add here that there is some debate in many conferences that there should be female specific guidelines or gender specific guidelines.
Yes.
So are you thinking that in cardiology also you require that certain sign symptom or certain scoring system should be there for gender differences?
So definitely, sir, because most of our studies and trials, they are based out of general population, or even if they are taking the cases, they take men into consideration, and the characteristics of men health into consideration more when it compared to other of aspects of the women. So there should be difference in the characters that should be enrolled into the trials, also the studies and investigations. Also, it has to be like pharmacological investigations. All the studies in mouse or other animals, they're all they are animal studies. They are not in female or male. So that also it has to come into future, I would say.
Sanjay sir, your call on this.
I think Vipul, while making the algorithm for all this scoring, QRACE or ASCVD, the gender is always taken into account. So the scoring is based upon the gender itself. And then I think, yes, some differences are going to be there, but otherwise that is inclusive in most of the scoring Euroscore or ASCVD or that. So I don't think that it would make a big difference as far as the guidelines are concerned. Gender specific guidelines I'm talking about.
Over to you, Taj.
Most of the things are common, but the things which we discuss, especially Dr. Shruti, which are peculiar to women, should be taken into account when you are addressing a woman.
So now we'll lightly touch upon cardiac rehabilitation topic, and then we'll open the session to questions. If you can enlighten us about what goes into cardiac rehabilitation, Dr. Shruti.
So cardiac rehabilitation is one important aspect. So cardiac rehabilitation decreases the mortality by 13 to 26%. So that is a big range, big number, I would say. Cardiac rehabilitation, nowadays we are seeing a lot of hospitals coming with cardiac rehabilitation department itself. So that has to be included in all the hospitals and all the treatment programs, I would say. So when we compare men and women, I think only 1/3 of population are enrolling into cardiac rehabilitation when we compare the number of men who are taking this rehabilitation. So yes, that also one of the points, which a very good point you have taken out here.
Shall I add to that?
Yes, sir.
Please, sir.
So unfortunately, in our country, once an intervention has been done, maybe angioplasty or bypass, people and doctor believe that the story is over and you are cured of the coronary artery disease, which is not the case, right? You have just treated that block. You have not treated the coronary artery disease or the factors which led to that. So cardiac rehabilitation is a very, very important thing, which is missed by most of our colleagues, including us. And unless we are very serious in recommending that, patients are not going to take it up. In US, you would be surprised to know that after a cardiac surgery or after a angioplasty, cardiac rehab is must. Then and then you will have the full reimbursement of the procedures or the further insurances. Whereas in India, cardiac rehab is not insurance covered. And that is why nobody takes it up. Maybe in some big cities like Mumbai, the hospitals have cardiac rehab centers. In Ahmedabad, 2 or 3 hospitals or the other centers who had started the cardiac rehab, unfortunately, very miserably failed. They could not get patients. So it is guideline recommended, as Dr. Shruti told, that it is very important to have cardiac rehabilitation, especially after a cardiac event or even after a cardiac surgery or angioplasty. Hardly 1 out of 10 patients actually go for that. So we need to, I think, do something, especially our cardiologist colleagues, to encourage this, because it is the way through which you are going to have better effort tolerance, improvement in the ejection fraction, development of the collaterals, so many other things, myocardial perfusion, everything will be improved with the cardiac rehabilitation, but that does not happen, unfortunately, in practice.
So that was not gender specific. That is general scenario that yes,
Yes, it's general.
everyone needs.
Everyone, men or women,
We have.
nobody goes for cardiac rehab, at least in our city.
Right, sir. Thank you so much, both the speakers. If any of the audience has any questions, we'll take it up. And Dr. Vipul, if you have any questions.
No, I guess it's a wonderful discussion. There were so many insights and so many evidence and experience-based opinions from both the speaker. We have Dr. Firdos. I would ask her if she want to make any comment before we take a final remark from our speakers.
So excellent talk by both the renowned speakers. I just have one minor query. I think sir and ma'am must have already answered it, but I missed the starting session. So to both of you all, sir, how do you balance the benefit and risk of hormonal versus non-hormonal therapies and managing both cardiovascular and glycemic health? And are there any specific patient profile that benefit one from the other approach?
Shruti, your call.
I think we have already had a good discussion on hormone replacement therapy. So hormone replacement, of course, estrogen declines during postmenopausal age group. So replacing hormone definitely has some cardioprotective effect, but it has shown that it has more thromboembolic events. So that is the reason nowadays it is not recommended for primary as well as secondary prevention of cardiovascular diseases.
And also the cancer.
Again, ma'am, yeah.
Yes.
And again, ma'am, just a very basic question, but a very relevant one. How do sleep disturbances and stress, which is very common during the post-menopause age group, how does that has an effect? Because I see the prescription from most of the cardiologists, zolpidem is like most favorite drug which is added on, but does it really help? And what are the long-term effects of, like, putting just on a sleep pill? How does it affect the cardiovascular health in the long run? And what can be done to make sure that such lifestyle factors are better taken care of?
So again, that has something to do with microvascular dysfunction, and inflammation is another important aspect, which is the cause for myocardial infarction. So there is increased oxidative stress, so release of all these reactive species. So all these things, they can cause myocardial infarction. So these things will happen when there is decreased sleep or a lot of stress. So they impact the cardiovascular diseases in this aspect, and also they cause obesity, overweight. So the abnormal circadian rhythm, it affects this way, I would say. Dr. Sanjeev, you can add on to this, I would say.
Sleep definitely. So deprivation of sleep definitely increases the cardiovascular risk, but the sleeping pills do not reduce that risk. So sleeping pill just to reduce anxiety is okay. But what happens sometimes, a woman is depressed, she is in depression. If you give sedatives, they would actually aggravate the depression. They are anti-anxiety things, or they are sedatives. If the basic cause is depression, you need to treat depression first, rather than giving her a sleeping medicine. melatonin in that regards may be a safer drug, and it is not associated with any negative cardiovascular health issues. So can be given for short term. Otherwise, non-pharmacological therapies should be tried first in all such cases. Maybe counseling and behavioral therapy or sessions. But rather than going on straight away to the sedatives, which is a routine prescription, I agree, from cardiologist after
That's
an
right.
event,
Yeah.
you should actually be trying to focus and figure out what is the exact cause, whether it is depression or whether it is anxiety. Both are absolutely opposite things.
All right. Great, sir. Thank you. Thank you, ma'am.
Thank you, Dr. Firdos, and thank you, all the speakers and moderator. It was absolutely superb session. So before I would go to all three speakers and take their final call and take home message, I would like to acknowledge once again that He for She program is a brainchild of Dr. Dhruvi, and she want to have such a session that empowers female health. Unfortunately, she is not able to join and interact now. But if she is here, I would like to ask her to give her some final remarks, and then we will take home message from the speakers. Dr. Dhruvi, are you there?
I'm here, but I'm driving. Thank you so much for taking care. And that's the exact, motto that the He for She campaign, the He is taking care of the, female health everywhere. Thank you, Fatak sir, for being there. And thank you, Dr. Chavda, for conducting the whole program along with Arjuni. Thank you so much.
Thank you, Dr. Dhruvi. Yes, the show must go on. And I would like to take home message and final remark, and what should be the one change that we should do in our practice to improve our cardiovascular health of female, starting with Dr. Sanjeev sir.
No, I think making women or the family members aware about the incidence and the prevalence of cardiovascular health overall in general and for women. So making them aware is the most important thing. And even in asymptomatic women, if she is high risk, I believe that routine screening should be done. And the symptoms should be explained to every family member that these are the symptoms. Early symptoms should never be missed, especially jaw pain, gaseous discomfort, acidity, shoulder pain, left or right arm pain. These are the symptoms which are often missed and are taken as something else. Only chest pain is cardiac? No, that's not true. Right-sided chest pain can also be cardiac. So these are the important symptoms which people, including doctors, ignore. Should be educated to every patient who is high risk.
So symptoms should not be overlooked by patients or underlooked by patients, and also by the clinician. It should not be underlooked or overlooked, and treat the symptom as a symptom, gender in non-specifically.
Especially gaseous discomfort and right-sided chest pain, they are often ignored.
Yes, sir. Dr. Shruti, your take-home message.
So, 70% of our acute coronary syndrome patients, they say that I thought this is gastritis. Yes. So gastritis, whatever they appreciate it as gastritis, may not be gastritis. So another thing, what I do in my practice is when they come for follow-up after the intervention or after their admission, may not be intervention or some after their treatment, when they come for follow-up, after talking to the patient, I catch hold of attender. So I tell them that you are also at risk for the same disease because they are genetically connected and they are non-modifiable. So they have to get screening done. So this is one thing what I have started in my practice.
Thank you so much, Dr. Shruti. And before I invite Dr. Tarne to give her final remark and vote of thanks, Dr. Firdaus, would you like to give some message for cardiovascular health of female?
So most important is education, education, and education. The basic symptoms and signs should be explained not only, as ma'am said, not only to the patients, but also to the relatives, because females tend to neglect their health. They tend to take care of everyone in the family. So their health is neglected. So education is very important. Knowing all these basic signs and symptoms are most important.
Thank you. Over to Dr. Tarne for final remarks and vote of thanks.
Thank you so much, Dr. Vipul. And thank you so much, both the speakers. Hopefully, someday we would not need he for she campaign and we'll all be apart. Thank you so much. It was very insightful.
But then the time would come, then you will have to run a she for he campaign.
The time is not far away, sir. Thank you. Thank you so
Thank you.
much, all. Thank
Great.
you so much.
Great initiative,
Thank you.
Dr.
It was
Vipul and
pleasure
Dr.
and
Devi.
great
Great.
honor to be
Thank you.
associated with this he for she event. And thank
Dr.
you,
Dhruvi,
Dr.
give final thanks if
Tarjani.
you want.
And it was very good interacting with Dr. Shruti. And thank
Thank you,
you, Dr.
sir.
Firdaus, Dhruvi.
Thank you so much, sir. Learned a lot from you. Thank you so much, ma'am.
Thank you, Dr. Tarjani, for inviting me. Thank you, Dr. Vipul. Thank you, sir. Thank you, Sanjeev, sir. It was wonderful discussing with you. Yeah, thank you so much. It's my honor, I would say. Thank you.
Yeah, we can stop recording, RX team.